So jumping into the myths about exercise, one of the first myths that we're going to talk about today is this idea that if I've never exercised before, it's too late to start now. And Jared and I probably hear this a lot more from our patients who may be in their 60s, 70s, 80s, or 90s when they come in and we prescribe exercise to address anything that they have going on. One of the common, responses we get is, well, I'm too old. This isn't going to work for me. And the reality is that there's no expiration date on your body's ability to benefit from physical activity. And there are plenty of studies out there that show that individuals who adopt an active lifestyle at any age can demonstrate improvements in strength, cardiovascular endurance, balance, and cognitive performance. And Jared, I don't know if you want to comment on this, but I think one of the, personally, I think one of the issues is that we as clinicians, either physical therapists, personal trainers, doctors, physicians, tend to look at our elder patients in that light of, well, I have to maybe be more careful with them because maybe they are more frail or more fragile, when reality is, they're not. And then what we do is we underprescribe exercise, and that's why people don't get better. It's not because they can't get better. It's that we're afraid to push these individuals and give them and apply the same strength training and cardiovascular training concepts that we would people in their 20s. Jared, do you have anything on that?
Yeah, no, I mean, you said what I was going to mention, right? The underdosing, and how a lot of times we'll see these people come into the clinic and we'll ask them to do a deadlift, right? Or we'll ask them to do a goblet squat. And it's pretty, significant resistance for what they've done before. And like, they'll look at you funny, like, oh, my doctor never told me to do this, or the other physical therapist or my personal trainer that I went to, never put on something like this. And, we have to educate these people, right? And everybody can be educated on this, not just your geriatric population or your older population, but everybody can benefit from heavier resistance training. And like it says in myth number 1, right? It's never too late to start with exercise. It's never too late to improve your mobility, never too late to improve your strength.
Yeah, great. And one of the things that we look at is the differences between those people who are active or who are maybe and those who may be sedentary. And if you look at this cross section of the thigh of a 74-year-old sedentary man and a 70-year-old triathlete, and that's, taking the thigh, if you were to cut it in half, and then you're looking down on top of it. And if you see the dense, darker colored section there is the muscle. The lighter white or gray shaded area, that's adipose or fatty tissue. And you can see the 70-year-old triathlete has much higher muscle density than the 74-year-old sedentary man. The point of this slide is to show that these are two people of similar age with very different body compositions. The reason why one looks different than the other is not because of an age issue, it's because of an activity component. And that is kind of the highlight here with us adding this slide. And I'll skim through this really quickly, but most of us know that there is a lot of benefits to exercise. We have a significant reduction in cancers. When you look at colon cancer in particular, a 45% reduction. When you look at type 2 diabetes, stroke, and high blood pressure, exercise can reduce your risk by 50%. And when we look at our typical healthcare model, though, when we go to approach our doctors and our physicians aren't typically prescribing exercise. They're prescribing a medication to try and keep your blood sugar under control, to try to manage risk of your stroke, to try to bring your blood pressure down. They're not recommending or prescribing exercise. And the reality is that exercise can do the same, if not better, and the side effects of the exercise are usually beneficial versus a lot of the side effects you might get with some of those medications. Anything to add there, Jared?
No, I mean, I think, understanding like the power of, like you said, the power of exercise, understanding that fact and knowing that like it can improve on all of these factors is very crucial for people to know and always keep in the back of their mind especially when they're like, oh, I don't want to go out and do this today, or I don't want to go to the gym. But like, see the benefits, see
Yeah.
how it can improve your lifestyle, and reduce the risk of like these, these things, dementia, heart disease, things like that.
Yeah. And one thing I might add, if there's someone out there who maybe is, oh, well, I already have diabetes or I already have this condition. I mean, I've seen, countless people that maybe have been able to reduce the amount of medication they've been taking by instituting exercise, even after they've been diagnosed with some of these things. So even if you've already been diagnosed with some of those, doesn't mean that you can't safely, add an exercise program to try to better manage your chronic condition. So speaking of the power of exercise, a 2017 study tracked exercise levels in 130,000 adults over 7 years. And what it showed that those people who had at least 150 minutes of physical activity per week were healthier than their sedentary counterparts. So they saw a 28% decrease in premature death and a 20% decrease in heart disease just based on this connection to physical activity of 150 minutes per week or more. Another, probably this is at least in the top 2 or 3 myths that I hear, is that I shouldn't run because running is bad for my joints. There is no research, there is nothing to back this up. There is no indication that running leads to joint damage or that leads to osteoarthritis. And in fact, research says kind of counters that. It shows that recreational running is associated with a lower incidence of hip and knee osteoarthritis, as well as an increase, as well as demonstrating that sedentary or inactive individuals actually have an increased likelihood of osteoarthritis than compared with those who run. And I think one of the common misconceptions is, I was a former runner myself, when we have an injury while performing our activity, we tend to associate our injury with that activity versus our injury versus the population as a whole. So if I'm a runner and I have an injury, I just automatically associate it with running's bad for my joints because I've heard that before. Versus maybe you would have had much worse knee problems if you weren't a runner. And the research shows that in all likelihood, you probably were better off that you were a runner than not a runner. So this is one of the most common myths that I hear in the clinic.
Yeah, and one thing just to add to that, Mike, is like, some people who have never ran before but want to start running, like they start to have knee pain or back pain, and they're like, see, I told you running's not good for my joints. But if you weren't a runner before, and then all of a sudden you start to run, you should kind of have that adaptation. Your joints should kind of go through that shock and awe kind of campaign. Even for me, like if I were to start to kind of run heavily, I'm not a runner by any stretch, but the moment I start to run for any sort of length of distance or kind of days consecutively, or begin a training program, my knees are going to hurt me as well. My back is going to hurt me as well. So there is a point where we need to kind of push through safely, of course, where we understand like, okay, my body is adapting to this type of exercise and activity. I'm going to have a little bit of joint pain, but my body needs to respond and needs to, again, adapt to that mode of exercise.
Yeah. And if you're somebody who's unsure about where that line is, that's when certainly consulting with somebody who's comfortable with that, like someone like Jared, who's comfortable guiding you through that, that's where that could pay a benefit. If you're unsure of how to progress that running program, if it's something you want to get back into and you're unsure about that. And then, speaking about, it kind of with the running aspect is that walking is enough when it comes to exercise. The reality is that most walking programs that people are doing don't stress the heart enough to create a true cardiovascular benefit. Most of us walk for the cardiovascular health. However, if you can still carry on a normal conversation while you're doing your walk, it's probably not stressing your heart and your cardiovascular system enough to cause a beneficial change. Just think about, if I were to try to strengthen my biceps and I was going to do arm curls, I'm going to want to use a weight that challenges my body so that my muscle adapts to that stress I'm putting on it to get stronger. We have to do the same thing with our cardiovascular system. So if we are not doing that, then we are not actually going to be training our cardiovascular system and getting those benefits that we're aiming for. If you're having trouble getting to a jogging program or anything in that in that realm, one of the things you can consider is interval walking, where you maintain your moderate speeds with short bursts of faster speeds, or light jogging that maybe start at 30 seconds or 45 seconds or a minute, and then come back down to your moderate speeds. And then as you recover from that, then you go back into one of those short bursts. And that's a way that you can start getting your heart rate up a little bit higher, challenging your cardiovascular system in order to get those cardiovascular benefits that you're looking for in the first place. And when we look at walking does tell us a lot. Research supports that the faster you walk, typically the longer you live. And compared to slow-paced walkers, moderate-paced walkers have a lower risk of premature death, as well as a lower risk of death from heart disease or stroke. And compared to slow walkers, brisker fast walkers have 36% lower risk of early death from any cause. And so we'll look at this a little bit more in a little bit as far as how speed correlates to mortality rate and predicting overall health and wellness. And that's kind of highlighted in a research article that was published by JAMA in 2011. And it shows and demonstrates that increased gait velocity is associated with higher survival rate in 35,000 older adults. That is a large amount of adults to be as part of this study. And that it can be used to predict the years of remaining life. And so we'll sometimes use walking speed in the office when we are putting a general conditioning program for somebody who may be older or may not be older, but just is otherwise not very active. And this can give us a good sense, a general sense of how healthy and well this person is generally. Myth number 4, again, probably one of the other top three that, most common that we hear: lifting weights is bad for my joints. Again, no evidence is in existence that suggests that weight training leads to joint damage or osteoarthritis. In fact, evidence supports weight training and its positive effects on the long-term bone health and long-term independence as far as your individual function. Even more recent, there's research that even suggests that weight training and running can actually increase the density of our intervertebral discs and increase our bone density. So when you look at something like osteopenia, osteoporosis, we know that loading the skeleton with heavy weights actually can help reduce that progression of osteopenia, osteoporosis, or it may, in some individuals, even prevent that from coming on or delay its onset. When you look at low back pain, we talked in several previous lectures, which you can see on our YouTube page, the importance of weightlifting for low back pain. When you have pain bending over to pick up a box, it's not necessarily that your spine is fragile. It's probably that we haven't trained your back and your muscles of your back to be able to lift that load. So weight training would be preparing you and training you to be able to lift that box up from the floor. So it's not that lifting the box or the weight is dangerous, it's that we just haven't trained you enough for that. When we look at the next one, squats will wreck my knees, lifting will wreck my back. So we already touched a little bit on the back, but again, there is no fact to this held belief. And when you look at the function of a squat, there really is no other activity out there or exercise as functional as a squat. I mean, Jared, I see you treating the clinic. I see that most of your patients are doing squats at some point in their plan of care. This is a foundational exercise for me. I hear all the time, though, my chiropractor told me don't squat. My physician told me I'm not allowed to squat ever again. And unfortunately, I hear my physical therapist telling me I shouldn't squat ever again. Right. The fact is we squat every day. You probably squatted to get into the chair that you're sitting in to watch this right now, or getting up and down from the toilet, getting in and out of the bed, getting in and out of the car. We're squatting every day. The best way to prepare ourselves to be able to do these activities is by training them. So the best way to train for a squat is by training through doing a squat exercise. Jared, anything to add on that?
No, I mean, you hit it right on the head. Like when everyone talks about like, oh, my doctor told me not to squat. Well, maybe they don't know how to teach the appropriate squat technique or form to help reduce that knee pain until your body is able to go through that exercise, right? That functional movement with pain-free. So, you know, again, Mike, you and I, we hear this a lot when we're in the clinic about like the first time, like we ask somebody to do a squat with knee pain or with back pain. And they're like, oh, no, I was told many years ago never to squat. I'm like, you know, how is that possible that you haven't been squatting all this time? And when you kind of educate them on, you know, how do you sit down in a chair? Oh, you have to squat. Oh, how did you go, you know, bend down and pick this up? Oh yeah, I kind of was bending my knees. I kind of was squatting. So it's just education on the benefits of it, how it improves your knee pain, how it improves your low back pain, and then coaching it up the right way to make sure that, you know, you can get out of these bad situations, get out of these painful situations, and then come back to it pain-free.
Yep.
Yeah.
So then when we look at the next one here, I can't exercise, I have bone-on-bone arthritis. Again, very common, something we hear weekly, if not daily. When we look at arthritis and this term bone-on-bone, we are learning more and more as the research comes out that a lot of these degenerative changes, arthritis, disc bulging, disc degeneration, are actually just normal parts of the aging process, just as gray hair would be or wrinkles on your skin would be. So when you hear the term bone on bone, that's a very scary term that people tend to start to avoid movement. And a lot of these studies that are coming out that we reference a lot in the clinic are studies that show how many asymptomatic people have bone on bone arthritis in their hips or their knees. So these asymptomatic patients or patients who have no pain have never had any idea that they had this bone-on-bone arthritis. So the idea here is that just because you have that show up on an image does not automatically mean that it's going to be painful. And therefore, just because you're having pain in your knee and you have an image that says you have arthritis does not mean that the arthritis is specifically causing your pain. The other thing is that research does suggest that one of the best things you can do for arthritis is to exercise. And so you can't have both these things be true, that research tells us that exercise is the best thing for arthritis, but that I can't exercise because I have bone-on-bone arthritis. The two things don't mesh. And when you look at what the research says, it says that exercise is one of the best, if not the best, intervention for arthritis. Anything to add to that?
No,
Okay.
that all sounded real good.
Okay. Man, nailed it on the head, huh?
Yeah, absolutely.
So myth number 7, I have chronic health issues that prevent me from exercising. This is one we hear a decent bit. I can tell you firsthand that I have had some chronic health issues in my past that have limited my ability to exercise a bit. But research does support that exercise improves symptoms for virtually all health conditions, from diabetes to heart disease to arthritis. For me, it was a chronic fatigue issue that doctors were struggling to diagnose. And I can tell you that one of the personal battles that I faced was not knowing where to start, or that fear of starting. Even as a physical therapist, knowing the benefit of exercise, I was hesitant to begin because I didn't know how it would affect me. And the reality is that everybody can do it. It just has to be dosed or modified to the right degree. And then as your body adapts to it, you should be able to do more and more. So as part of my recovery, I started out walking on a treadmill for 15 to 20 minutes a day because that's what I could tolerate. Now I can go for a 25-minute run and still go about my day without having the same, and I can tolerate more of that despite still having some of these health issues. And actually my symptoms have continued to improve over that time. So just because there's a chronic illness doesn't necessarily mean that it should prevent you from exercise. It just might be that you need to consult with somebody who can actually help guide you in the right way to start. And then the other part of this is, we touched on this earlier, exercise can also reduce the reliance on medications to manage chronic health issues. Most commonly, diabetes, blood pressure medications. Even if we can't get you off of those medications with exercise, if you can reduce the load that you have to take in order to get those results, it's certainly going to be better on your system taking a lower dose of a medication than taking a higher dose. High intensity interval training is dangerous. This is another myth that we hear. So when you look at recommendations from the World Health Organization, the recommendation is 150 minutes of moderate intensity aerobic activity, or at least 75 minutes of vigorous intensity aerobic activity weekly. And according to a 2011 study, of 62% of exercising adults, only 10% of them met the actual recommended guideline, which means that how many people out there who are exercise, let alone all those people out there, period, are getting the right amount of physical activity that they should be getting on a weekly basis. When we look at moderate and vigorous activity, moderate intensity exercise is defined as 3 to 4 times as much energy spent as you would resting. And obviously this will vary depending on your individual fitness levels, but this would include a moderate increase in heart rate and respiration rate. This would include brisk walking, light effort cycling, pickleball, and doubles tennis. Again, if you can hold a normal conversation while you're doing it, you're probably not working or working or challenging yourself as much as you probably should. That doesn't mean that you should be huffing and puffing. You could still maybe get some words out, but you don't want to be able to hold a conversation like Jared and I would be here now. When you look at vigorous intensity exercise, it's defined as 6 times as much energy as your resting state. And again, varies based on fitness levels, and this would include a significant increase in your heart rate and respiratory rate. Some examples here would be hiking, jogging, fast cycling, tennis singles, and then moderate weight training. So when we look at those, again, if your activity is more in the moderate, then you should be looking for 150 minutes per week. If your activities are more vigorous, you should be at least shooting for 75 minutes per week. And then when we look at the weight training exercise prescription, and Jared's going to go over some exercises here momentarily, we want to cover a few key terms, and I'll turn it over to Jared and he can discuss some of the key terms that he's going to talk about when we go over the exercises.
Yeah, so one thing that we hear all the time, like when you're looking at YouTube videos, right, you're looking online, is people are throwing around these words here, right? Strength, power, overload, progression. And a lot of times people think that they are all intertwined, like, oh, it's like I use strength and power, like that's the exact same thing. But in reality, they all have a different purpose. And again, this is going to be on YouTube later. So if you are looking through this and you're trying to read the definitions, it's going to be on. You can certainly go back to this, find it, and look at it. The biggest one that we're going to talk about here is going to be overload and progression. We've all kind of know what strength means, pushing an object dependent of time. So, it doesn't matter if it takes 1 second or 10 seconds. If you're able to push that object, that's strength, right? Power is taking that same exact weight and moving it as fast as you can. Overload is assigning a workout or training regimen of greater intensity than the person is accustomed to. So when Mike was talking about his bicep curls earlier and having a load greater than he could tolerate for a certain repetition, that is overload. So now his body going through bicep curl understands that, okay, if this is going to be the new normal, he's going to overload. This is a heavier weight. I need to adapt and grow to that. So that is the idea of overload. And progression is promoting long-term training benefits. So if we look at an exercise program, let's say we leave today, we strike it off with some of you people. You're like, yes, I'm going to start an exercise program. I'm going to do 10 squats a day. And you do that for an entire year. Early on, you will see benefits. You will see a benefit. You will see adaptational change, neural change as your body does kind of adapt to that exercise. But eventually, you're going to plateau off. You're not going to get any stronger. You actually will get a little bit weaker because your body has now adapted to that. And now that's your new normal. If you progress and you continue to overload and progress, continue to overload, then that's the long-term change that you're looking for. That's how you continue to get stronger. That's how you continue to improve the resilience of your body. Going back to overload here, or going back to our training, let's talk about that real quick. Right? When we talk about resistance training, that sounds pretty intense. Like, oh man, you got to get the weights and barbells, you know. Resistance training can be your own body weight, doing this multiple times, squatting down, squatting up for 3 sets of 10. That can be your overload. That can be your progression. So going into our exercises here, yep, that's fine, Mike. We'll go on to goblet squats here. Okay, so the big thing about squats, the goblet squat just means that the weight is in front of you. You've also may heard of a front squat. Those are similar exercises, meaning the weight is on the front of you, not on the back of you, like a barbell back squat. Big thing that we want to focus on here is pushing your hips back and initially keeping your knees behind your toes. When you pass that 90-degree mark, so if you see the picture on the right, I'm just about getting to 90 degrees. My knees will actually drift in front of my toes. And that's another myth that we see all the time of, oh, like, you know, I was told, never put your knees in front of your toes when you squat. Initially, that's true because we want to make sure that your weight goes back and that you have the proper hip hinge, meaning you bend at the waist first, and then you bend at your knees, getting you into this position here. A lot of times we'll have people who will have knee pain, right? So if I have knee pain when I squat, like it always happens, what's the big deal? This would be the first thing that Mike and I would be cueing you on, is pushing your hips back first and distributing your weight, not through your toes, but through kind of the middle of your foot and then closer to your heel. That can help reduce your knee pain because it's going to help reduce the stress placed right through the front of your kneecap. A lot of times too, we'll have people who have low back pain with squats there as well. A lot of times that's just about arching the back or rounding the back and getting a more kind of rigid spine. All right, there is no perfect lifting technique, but we want that neutral spine so that we can get into this good hip position here. So if we go on to the next one here, we're looking at a deadlift. So a little bit different, but still the same concepts apply, is terms of you want to be able to move at your hips while keeping a neutral spine here. So a deadlift is a great exercise. You know, if you're reaching down to grab something heavy like a kettlebell, if that's what you're using to lift with, or just household activities like picking up your laundry basket, being able to lift that. Lifting a child, you can do a goblet squat or a deadlift to make sure that you protect your back if you've had back problems. But looking at the technique, pushing your hips back, hinging at your waist, and having a slight knee bend here. If we go through the next exercise, right, we're looking at a lunge. Okay, so this could be a progression from your squat into a lunge, which is now working the quads, the muscles on the top of your legs, in not both legs, but only in a single leg fashion. So that can be, you know, like we talked about before, you know, resistance training kind of scares me, lifting weights. Well, that's fine. Now, if you're doing squats, you move on to lunges. Big thing here, the back leg, you want to make sure that your knee doesn't slam into the ground. You want to be under control when you tap down and then when you stand up. A lot of times we'll see people who have knee pain with this as well. And Mike and I will give that same cue that if that front leg isn't out far enough, you're more likely to get on top of your toes and then lean over top of your toes with your knee and then stress that knee joint there as well. If you're still having knee pain after shifting your weight back, maybe don't go as far down initially. Right, so a lot of times with arthritis, there will be certain areas that will be inflamed, right? That's what the joint is. That's what arthritis means. The bone is inflamed. So taking yourself out of those positions and kind of limiting your range of motion and then slowly working into it will help with synovial fluid going in and out of the joint. And then from there, you'll be able to move into that range of motion and then get down into this position here. So go into some ground exercises. right? A dumbbell weighted bridge is a great exercise to be able to focus on glute and hamstring strengthening in a non-weight bearing position. You can certainly use a weight if you have one at home. If you don't, you can focus on grabbing a gallon of milk, right? Or a gallon of water, or you can use anything that's going to kind of provide a little bit of resistance. You can put that right on your hips. We like to use this one a lot in the clinic when people have back pain, because usually, not 100% of the time, but there are times when you have back pain, it's because your glutes and your hamstrings are weak. So by doing this exercise, and the progression of this would be going from both feet to 1 foot, and then adding in some other resistance there. But improving that glute and hamstring strength is going to help reduce that low back pain, because you're improving on the areas surrounding that. You're improving the hip the strength around that low back, and then providing support that way. All right, so moving on to our lateral band walks. If you don't have a band at home, that's okay. You can certainly do this exercise without it. You're going to feel the resistance. You're going to feel the exercise working the exact same way, but a band will provide a little bit more. The key to this one is making sure that you keep your knees slightly bent, and that when you take your step, you're taking it far enough out where you're feeling resistance, and then on coming back in, so from the first picture to the second picture and then back to the first picture, you make sure that that leg doesn't come and slap back in towards the other one. One, that's not the purpose of the exercise. Two, it could be a balance problem, especially if you keep a narrow base of support and your feet are tied. You may have difficulty transferring and stepping. So we want to make sure that we're safe when we do that. But why do this exercise? We want to make sure that we just talked about strengthening hamstrings and glutes. Now we want to focus on those hip abductors, those muscles on the sides of your hip. Again, providing support to the low back, providing control of the lower extremity. So if we're talking about knee pain, ankle pain, back pain, this is addressing all those areas, because when you run or you walk, these muscles on the sides of your hips have to activate and turn on to keep your pelvis level, so that you don't have that hip drop, or you don't have your knee cave in, or you don't have your foot roll. So if you see like your normal arch of your foot, and then all of a sudden as you walk it flattens out, everyone thinks, it could be an ankle problem, let me get orthosis, let me do this and that. And an orthosis, or an orthosis may help strengthening your hip muscles up enough to stabilize you, could provide more long-term benefit there. Okay, the rack position is just a weight you can put on the side. You could put that in front of you, or you don't have to use a weight at all. That's just another option. So now let's work on some upper extremity exercises here. All right, so we talked a lot about hips, low back, knee pain, ankle pain, but now we're going to work on dumbbell bent over row. Again, you can use a gallon of milk, you can use water, you can use a can of soup if that's enough resistance for you. The key to this exercise is making sure, one, that you have slight bend in the knees, that your back is as straight as it can be, and that you're pinching your shoulder back and not just driving your elbow. If you're not pinching those shoulders, you're not getting the full benefit of the exercise, and you're going to end up stressing the anterior or front of your shoulder more than you would if you get that good scapular retraction. This is a great exercise for anyone who's got neck pain, because all day we've been sitting in these chairs and we've been kind of hunched over like this, right, typing, and everyone does it, myself included, and you have to have those reminders to kind of sit yourself up. But all of these muscles on the back are going to get extremely weak, and with that weakness comes a lot of neck pain, a lot of anterior shoulder pain. So this is a great exercise to help prevent that by strengthening those scapular stabilizers and then bringing that posture back up. All right, so focusing strictly on the shoulders now. This is a great exercise to do in case you're just willing to build up your delts. Again, working on your posture to get yourself back. Assisting that rotator cuff, which is the muscles that kind of help keep everything and move you out and move you back in. Just an exercise to build up delts, upper trap there as well. Again, general shoulder girdle strengthening. And then we have the next exercise, which is our dumbbell press or overhead press. This is an exercise I would do if I knew that I didn't have any shoulder pain, especially if that was underneath or in front or on the side. You may feel that, because what we are worried about is shoulder impingement. Now, we have videos on YouTube that talks about rotator cuff tendonitis, rotator cuff tears, labral injuries there as well, so you can check that out. If you're cleared of all of those types of activities or those type of pathologies, excuse me, a shoulder press is going to be a great exercise, because not only is it going to be working, you know, your anterior, or excuse me, your pec muscle, superior pec, all your delts, right, anterior, middle, and posterior, but you're going to be working those rotator cuff muscles in a stabilizing fashion. So to kind of help you pushing up overhead, you need those rotator cuffs to keep the shoulder in place as you rotate, so that everything kind of stays smooth, everything stays in line, and we can prevent those sort of tendon injuries that usually occur. If you are having pain with something like this, I would definitely reach out to a healthcare provider first. You know, hopefully physical therapy, that would be better than your orthopedic surgeons, you know, throwing my bias out there, because we can help kind of correct that technique. And if we can't, and you're still having pain, then we know that there's a bigger factor at play, and we need to find that out and correct that there. All right, so our recommendations, right? Where are we going to start? If you're a beginner, one thing that you can do is start with a lighter frequency, 2 to 3 times a week. And then if you're intermediate, if you've been lifting for, let's say, greater than 3 years, you're kind of considered an intermediate. And then advanced would be some of your higher level athletes who need to train at a more frequent time during their week, so that they can really hone in on their skills, build that strength, build that power. So let's just say we're all beginners here, right? We're going to be working at 2 to 3 times a week. And if I'm looking to improve on my strength, right, we're looking at repetitions of less than 6. So I know we've heard all the time that, well, you know, I've been working out, I've been doing sets of 10. Well, technically you're working in your hypertrophy phase. Now you will get stronger because there is some crossover, but to get a pure strengthening phase, you need a weight heavy enough that within 2 to 6 repetitions, 2 to 6 sets, you can only do about 6 repetitions. So that's one thing that if you're lifting at home and you think you're building strength, you need to make sure that you're working appropriately. In the clinic, we like to work right in that 6 to 10 range if we're going to work on that strength and hypertrophy type of phase. Again, we don't really do a ton of power work in the clinic. That's for more of your skill specific, or maybe you're late in training. But these are just some guidelines that you can use when you're building your own program, so that you can see, okay, this is what I want to try to focus on. I know the sets, I know the reps that I want to try to work, and then again, progress the weight from there, or progress the repetitions per there, so that you can kind of get more resilient, decrease your pain where you can, and just improve your lifestyle there. All right, so this little thing here, right? The most reliable indicator of your future health is your ability to move. So like Mike was talking about earlier, with gait speed, with your ability to get into a deep squat position, with your ability to climb stairs, with your ability to get in and out of bed. These are huge indicators of your future health, and it's very imperative that if you haven't started lifting or you haven't started exercising, that you do so, because like the number one miss said, it's never too late to start.
Great.
All right.
And so if anyone has any questions, we can certainly open that up now. So if anyone has any questions, go ahead and type those in, and we can answer any of those as we have them on here. And then if you don't have any questions, the other thing you can do is you can always reach out to us. Jared and I are always available by email. You can also reach out to the kineticptpa@gmail.com as well if you have any questions and would like to reach out to us that way. So, Jared, it doesn't look like we have any questions, so we can probably wrap up there.
Yeah, Mike, you just go to that last slide real quick.
Yeah.
So again, guys, like Mike was talking about, oh, I'm sorry, go to the last slide, the contact us one. Yeah, so like Mike was talking about, there's our emails at the very bottom. And again, if you can't write it down real quick, that's okay, because this is going to be on YouTube very soon, so you'll have that to write at. And then follow us on our social media for more of these, information on the new webinars that we're going to be doing and any sort of content that we're putting up. We're doing a lot of shoulder lectures right now. We're talking a lot about, blood flow restriction, things like that. So if that interests you, please feel free to look at that stuff and reach out when you need to.
Yep. And then, as always, the webinars, as we complete them, will be posted on the YouTube channel.